Hi, welcome everybody. My name is Mary Koshi. I'm with the Office for Diversity and Inclusion. And welcome to the Office for Diversity and Inclusion's virtual speaker series in recognition of Disability Awareness Month. Today we have with us Dr. Jenny Lieberman from the Department of Rehabilitation Medicine and Human Performance. And Dr. Lieberman will be speaking to us today about building physician skills and competencies in the care of people with disabilities, how to increase inclusivity in the clinical environment. I also want to point out that this session is being recorded, so it will be made available to you for future reference. And also we have the closed captioning available to you as well. If you don't see the subtitles on your screen, you can go to the toolbar for Zoom and there's a CC button. You could go there and say view transcript or view subtitles, and you should be able to see the closed captioning. So again, welcome. And with that said, I'm going to pass it over to Jenny to take it away. Thank you.
Good morning, everybody. Thanks for joining today. I am going to pull up my screen in just 1 second and just to go over what we're going to talk about today. But I appreciate everybody taking their time to spend 45 minutes to an hour with us this morning. Okay. So today what we're going to be talking about is building physician skills and competencies in the care of people with disabilities. And while it's important for all physicians to obviously have competencies and be able to take care of all their patients, there are specific things that are more focused towards working with the population of persons with disabilities. And that's what we're going to touch on today, just to give you an idea in terms of some of the areas that you should have some awareness on and what you should be thinking of when you're working with a patient who has a disability, regardless of their disability. So the plan for today is first, we're going to just go over who is the patient with a disability, just to kind of get a little clarity in terms of what I'm talking about. We're going to look at some of the difference in the assessment process and why this might be a little bit different from patient to patient. What our patients with disabilities want, and in their own words. So what I did prior to putting this presentation together is I actually sat down with a number of my patients and asked them, what would you want your physician to know when you came into their office? What would you want a physician in the ED to know? What would you want a physician who you're seeing for the first time or for the 50th time to know when they're sitting down and talking with you? We'll talk a little bit about how anybody in healthcare, a physician, a nurse, anybody that we're working with who's working with the population can be a better provider. And then we'll have a conclusion and I'll give you the opportunity for questions at the end. However, if as I'm going through all this, any questions come up, please don't hesitate to put them into the chat and we'll discuss them as they come up. So first to start, who am I and what do I know about persons with disabilities? I'm an occupational therapist. I've been practicing as an occupational therapist since the mid-90s. So I've seen a variety of disabilities, a variety of patient populations over the years. I'm an advocate. I have spent a lot of time working with the population with disabilities. I've been to DC, I've been to Albany, I've been to various hearings to speak with Medicaid about access to the needs of persons with disabilities, ranging anywhere from complex rehab technology to supplies to home care services to OT and PT services. I'm a researcher. I have a PhD in occupational therapy. I did research for that. My focus was on the spinal cord injury population. I'm an educator. I love educating people on any issues surrounding disabilities and complex rehab technology. And if you got me started on this, I could probably talk for hours. So it's a good thing that I have a time frame. I am a friend. Two of my best friends are people with disabilities. And so I have personal experience of not just listening to them talk about their lives, but actually being with them in varying environments, whether it's out in the community, whether it's actually going with them to their doctor's appointments. And I'm a family member. I have family members who also have disabilities. So I kind of run the gambit. And so I have a lot of experience working with this population. And so I feel having that experience kind of gives me a little bit of an umbrella of a better understanding of what my patients are looking for. So really, who are our patients with disabilities? And it runs the range. We have patients who have neurological diagnoses, spinal cord injuries, paraplegia, tetraplegia. They've had strokes, they have hemiplegia, ALS, cerebral palsy, MS, spinal muscular atrophy, this whole range of neurological diagnoses. There are also individuals with orthopedic diagnoses, rheumatoid arthritis, osteoarthritis, fibromyalgia, low back pain, which we see a lot. There are patients who have medical diagnoses, including cardiac disease, congestive heart failure, coronary artery disease, respiratory problems, pulmonary hypertension, COPD, neuropathy. We have a large number of patients that we're seeing now with post-COVID syndrome and the subsequent disabilities that come with that. Autoimmune disease, POTS, postural orthostatic insufficiency and stability. And then we've been working a lot with transplant patients. And so our patients with disabilities really, as you can see here, they run the range. And what's important to note with this large range is that even though these are all different diagnoses, they often can present the same way. And it's very important to think that way as a physician, that your individual who has a diagnosis of rheumatoid arthritis, for example, could present as somebody who has a neurological diagnosis. They don't have the range of motion to sit up. They have joint deformities, and so they're contracted, they have imbalance, and so their ability to function can be just as impacted as the person with a spinal cord injury. Likewise, your individual with a respiratory disease or an autoimmune disease can have the same level of disability as somebody who has, you know, for example, multiple sclerosis or, you know, CP. I mean, there's a varying range of diagnoses, but a lot of times they'll present very similarly as it comes to their level of disability. And so the members of the care team, there's a lot of us. There's the patients. I like to think of our patients as our consumer or our clients. So while we are a healthcare institution, these are consumers that are coming in to see us. They're clients. They're people from our community. They're people that are traveling to come see us. So thinking of them not just as patients, but also as consumers and clients really can kind of put things into a little bit of a different perspective. There are their family or their support network. So who's taking care of them? Is it a parent, a spouse, a sibling? Is it just a home attendant? Is it a home attendant that changes week to week? And so understanding that support network. Who's their primary care physician? You could be their primary care physician, in which case you're a very integral part of the team, because oftentimes you're the one that's sort of overseeing this umbrella and helping to keep everything running. There are specialty physicians. So you have your neurology, gastroenterology, urology, respiratory, cardiology, orthopedics, et cetera. And every single one of our patients on that list of disabilities could fall under all of these specialty physicians. There's a social worker. The social worker is also an integral part to this, because the social worker is the individual that's going to help them set up their services. It's going to help them set up potentially their insurance. It's going to help them with all of their social supports in the community so that they can function. And there's the rehab team, and the rehab team consists of occupational therapy, physical therapy, speech therapy, rec therapy, physiatry. It can consist of neuropsychology. So your rehab team is pretty extensive and expansive. Any questions on this part in the beginning? If you have any questions, feel free to just throw them into the chat. So here's the question, and this is partly why we're doing this today. What do patients with disabilities need that's different from patients without disabilities? The answer, really nothing. They require the same level of care that we offer to any patient, regardless of their physical capabilities. So, you know, regardless of whether one is able to get to easily or not, they still require the same level of care, and they deserve the same level of care, and they deserve the same level of respect. What does that mean as the healthcare provider? Knowledge, having knowledge on diagnoses. So if you're working with somebody who has a spinal cord injury, well, you don't need to be specialized in understanding that they're, oops, sorry about that. That understanding that they, you know, what can happen with having a spinal cord injury in regards to all of the urological, all of the skin care, all of those very specific things, it's very important to have an understanding that this exists. So, for example, the individual with the spinal cord injury having understanding that they could get a UTI, that they could have a problem with their skin, that they can become dysreflexive. And so having an understanding of those different diagnoses. Having an idea of future considerations. So if somebody comes in to see you and they have a progressive diagnosis, understanding what the progression is like, understanding if it's somebody with a diagnosis of MS and which type of MS versus a diagnosis of ALS versus cerebral palsy. So is this something that's going to have a rapid progression? Is it something that's going to be sort of a chronic progression through the rest of their life? What's the social implications of this disability? Thinking in terms of, you know, if a person is on certain types of social supports, they maybe can't get employed. You know, maybe they live with a spouse who works full time, and what happens to that relationship with their partner, and they need specific levels of care. What are their functional needs? So have a basic understanding of, you know, if it's somebody who has a respiratory disease versus a neurological disease, what do they need functionally to be able to live their lives? What's different from population to population? And what are their emotional needs? And this is one of the oftentimes more important components, because our consumers, our clients, our patients are coming into our office looking for very specific levels of assistance and help and medical care, and at the same time they're coming in with lots of you know, personal issues that are around disability and how to be able to be out and functional living their life. So we're going to talk a little bit now about the patient experience, and this is sort of where I kind of get into the nitty-gritty of why this is important. So like all patients, regardless of their ability, their experience begins at the front desk, at the entrance to the building. So what could be different for our patient that comes in? Maybe they can't reply to us at the front desk because they can't speak. So we ask them a question, they don't reply. They're not being belligerent or non-cooperative. They just can't speak their response to us. Maybe they can't write because their hand function is impaired. They have a spinal cord injury. They have rheumatoid arthritis. You know, they have a neuropathy and they don't have sensation in their hands, so they can't properly hold a pen. Maybe their responses are delayed. They have a speech disorder, and so when they're speaking, their response to the question is delayed. Maybe they have a neurological diagnosis and they're having a really hard time forming their words. So where might the assessment differ between the person with and without a disability? I've listed on the screen 8 different areas that we'll look at, and some of them I'm going to talk a little bit more in depth about than others. Weight, secondary diagnosis, medication and treatment, equipment needs, and equipment needs runs the gamut of mobility needs. It could be a wheelchair, it could be a walker, it could be a cane, bladder and bowel management, a hospital bed, a Hoyer, having some understanding of the equipment needs. Transportation, how does our patient with the disability get to our office? And, you know, while we are fortunate in some regards living in New York City that we have some accessible transportation, buses are much more accessible than subways are, but there's accessible taxi services. You know, being aware that if somebody's coming to you via a specific form of transportation, that's going to affect their arrival time. Issues of access, support service, and insurance requirements. Weight's a big one. It's what I want to talk about first. And I'm not, you know, making a pun there with it being a big one, but it really is a very big issue here. So question, how often do you weigh your patient in a wheelchair? Less than 5% of patients in wheelchairs are weighed at regular appointments. Less than 5% of pregnant patients are weighed during pregnancies. So think about that. You have somebody who has a disability, who's in a wheelchair, who's coming up to see their primary care physician. They're going up to IMA. They're going to 98th Street to see a physician, and they're not getting weighed, and they're getting prescribed medications. And many medication dosages are based on somebody's weight. And so we're guesstimating their weight because we're not weighing them. If you're guesstimating somebody's weight, then you're not providing proper management. Giving somebody an inaccurate level of medication doesn't provide them the proper care. Same thing when you're working with a pregnant woman with a disability. If she's not getting weighed, it's a lot harder to keep track of how the baby is developing, how the mom is managing in terms of, her time through her pregnancy. Again, we're not able to provide proper management if we're not able to weigh a patient. So here's a direct quote from one of my patients. They tell me they can't weigh me. I'm trying to lose weight. They told me it's too hard for them to weigh me because I'm in the wheelchair. How can I try to lose weight and get healthier if there's no way for me to keep track at my doctor's office? It makes me feel like I'm not as important as the other patients. I sit in the waiting room, and it's a reminder of how different I am. So this is an individual who said to me, and this is somebody who's been trying really hard to lose weight. It's a person with a spinal cord injury, and they can't get weighed at their medical doctor's appointment. And so they can't keep track of what's happening with their weight. So they can't try to get healthier. And that statement there, it makes me feel like I'm not as important as other patients. As a provider working with this population, we should be making sure that all of our patients feel like they're included and that they're all as valuable as the other one. And so what are some of the possibilities and considerations here? And I know that on some of the units we have scales, but maybe we need to have more scales. Maybe sometimes it's hard to get somebody out of their chair onto an assessment table to then weigh their scale. Maybe we look at options of having assessment tables with scales or Hoyers with scales. Maybe we look at having some way to have in the chart a specific location that talks about the weight of the chair or the weight of the individual and the weight of the chair. If we know the weight of the chair, we can just weigh them on the wheelchair scale. And if you can't weigh them, which certainly is a possibility, even having the equipment, sometimes technology fails on us, and so we can't weigh them. If you can't weigh them, then at least validate their concerns and say to them, I understand that you're very upset over the fact that we can't weigh you today. I understand that makes you feel like you're not as important as our other patients. I want you to know that this is a very important thing to us, and we will resolve this in some fashion, just so that the person who comes to your door feels like you actually are concerned about their well-being and their health. Any questions on weight? If so, feel free to drop something into the chat. Secondary diagnosis. Again, as I said before, knowledge is key. Research is important. Know your primary diagnoses and your secondary diagnoses and disabilities, and ask the right questions. So a perfect example here is when we're talking about, I'm going to use a person with a spinal cord injury, for example. Knowing that somebody who has a spinal cord injury could have what's called autonomic dysreflexia. And a lot of patients I've had who are having specific symptoms with autonomic dysreflexia have gone into doctor's appointments and have been admitted to the hospital just because of the fluctuations in their heart rate and their blood pressure. And what autonomic dysreflexia is basically, it's the body's response to a stressful stimuli, and it can cause your heart rate and your blood pressure to oscillate quite frequently. And it's important to know because, one, if you're working with somebody who has a very high blood pressure or heart rate, it could be because there's some stimulation there that's causing this to happen. For example, they could have a problem with their skin. They could have a UTI. They could have a bunched up sock. Their catheter could be kinked. So knowing these things allows you to intervene before you automatically send them off somewhere to like the ED, which is a place that none of our patients want to be sent to. If you're able to, look at the patient and you determine that their catheter is kinked, you can unkink their catheter, monitor their blood pressure, and if you see that it's gone down, do education with them, and then allow them to go home. Another consideration is if somebody's having the alternative effect, if they're having issues with their blood pressure dropping, and they're orthostatic, which happens a lot with spinal cord patients. It can happen with POTS patients. It can happen with some of our MS patients. And so just having a good knowledge of what are some of the secondary disabilities that are coming with their primary diagnoses so that you can provide the right level of care in the moment and prevent maybe having to put somebody in an even more unpleasant situation. So here again, this is in terms of second diagnoses. What are our patients saying? When doing a virtual visit specifically, I constantly have to remind people who aren't my PCP that I have a disability of some sort. So even if I'm going to doctors in the same system, not everything pops up, or they don't do a full review of my chart before I even step in. It feels like they're figuring it out on the spot as they see me. So while it seems kind of obvious that we should be doing a chart review before patients are either popping up on our screen or coming in, it's almost even more so when you're working with someone during a virtual visit, because we're not physically seeing them. So we can't see if they're sitting in a wheelchair, if they're in a power wheelchair, if they have any type of a contracture, if you notice that there's any change in terms of their lower body, if there's some swelling. And so, being able to do that review in advance really goes a long way for our patients with disabilities, feeling like we're present, we're there to help make sure that they can get everything that they need, and we're going to provide them with the right level of care. This is another one that I'm going to touch on for a little bit. I went to the ED and they left me on the stretcher for hours. I told them I needed to be moved, but they didn't. I can't move myself. Now I have a pressure ulcer, first one in 10 years. They should have known better. So while the emergency department is a very active place and a lot of patients are coming and going, and every physician and nurse has an overload of patients, there are certain things that can make a huge difference in terms of providing care. For example, this was a patient of mine with a spinal cord injury who could not move himself and had told the staff that he couldn't be left lying on his back on the stretcher because of the risk for pressure ulcer, and nobody listened to him. And they left him lying on his back, and he got a pressure ulcer, which was the first one he had in 10 years. And it lasted for him to be able to heal this ulcer. It took him over 2 years for it to go away. So just paying attention to some of the little things, knowing there's a patient with a spinal cord injury in my ED, in my bay, I need to make sure that we're moving them, we're adjusting them, we're keeping them off of their back for long periods of time, we're keeping them off of their side for long periods of time. So just a little bit of knowledge can go a long way, just with our patients feeling like they're being heard, but also in terms of providing them with more long-term care. So here are some considerations. Do a thorough chart review before you see the patient. Introduce yourself, acknowledge their history, ask them if they're still experiencing the symptoms they were previously experiencing, and validate their concerns and symptoms. So introduce yourself, present it as, I know that this is what, this is your diagnosis, this is how long you've had it. I saw that in the chart in the past, you had an issue with having a pressure ulcer, you had an issue with low back pain, you had an issue with swelling in your ankles. Are these symptoms still present? If so, what's going on? How are you feeling about them? While all of this seems very obvious to do, it doesn't translate to our patients. So our patients aren't actually experiencing and understanding that we've looked into the chart, that we actually have some backstory on them. And I've been told this by many, many patients that come through my door. Another one, medication treatment. What are our patients saying? I'd like my doctor to maybe suggest treatments that are not straight up medication based, maybe a little more homeopathic. A lot more doctors are prone to give random medicines in general, which for me, I feel has felt like overprescribing medications. I get chronic UTI and no one has ever discussed alternatives like diet and alternative interventions in place of super strong medications. And so here's an individual who has gotten chronic UTIs and has been overprescribed antibiotics without anybody ever looking at his diet or his level of care. And because he was overprescribed antibiotics, he developed antibiotic resistant UTIs that couldn't be treated. This is an individual who actually went to another institution where he was able to get treatment with diet-based interventions, with more homeopathic-based interventions, and he's been able to stay UTI-free for quite a while. And so, having some simple understanding, and if we don't, because that may not be our area of specialty, referring somebody to go see a physician who would be better able to assist them with the care. I just mentioned UTI here, urinary tract infection, just because I know several of the individuals that come through my door who get chronic UTI and get overprescribed antibiotics, but there are so many other secondary diagnoses that we treat with a medication before we address diet. So here's equipment needs. A wheelchair is not a wheelchair is not a wheelchair. I know that sounds silly, and I've said that to people before, and they say, I have no idea what you're talking about. But a wheelchair is not a wheelchair. So, you know, a patient will go see a physician, and the physician will just prescribe them a wheelchair and put in an order for a wheelchair. The consequences of that are that an individual could be stuck with this piece of equipment for a very long period of time. And so you get somebody who has a permanent disability, a very standard wheelchair, and we can't replace it for them. So they end up developing secondary disabilities from being forced to use this piece of equipment. They develop back pain, they develop shoulder pain, they develop pressure injuries. I see this every day from people coming through my door. So just having an understanding that there are different types of equipment that exist based on different levels of disability. And again, if you don't know this, come and visit me in the wheelchair clinic. I am down there every day and we see patients full time. What is functional mobility? It's not always functional to walk or push yourself in a wheelchair. So thinking about the population with disabilities that comes through our doors, we want our patients to be as mobile as possible for many reasons. We want to make sure that they're able to maintain a healthy weight. We want to make sure that they're able to maintain good cardiac function, good respiratory function. But is it really functional to walk long distances to get to the store if you can't get to your doctor's appointment through an ambulance service and you have to take a subway? Is it really functional for them to walk distance over hills? Or is it really functional for somebody to push themselves in a wheelchair to get from point A to point B? You know, our upper body was never designed to really move us. It's part of the reason why the muscles in our legs are so much bigger than the muscles in our arms. So maybe it's not functional for somebody to push themselves in a wheelchair full time. Maybe it's not functional for them to walk. So think, what's functional? What other types of equipment should you be considering? Thinking about catheters, thinking about commodes, thinking about hospital beds. You know, while it's not necessary for physicians to know the different manufacturers of catheters, the different manufacturers of respiratory equipment and commodes, it is important to have an understanding that these are very specific needs for our population with disabilities, and they can have complications if somebody doesn't have the right equipment. For example, if somebody's not getting catheters frequently enough, or they're not getting the right form of catheter, they can get an increased risk of UTI. They can develop an injury in the process of catheterizing themselves. So thinking about equipment needs. Any question on that? So here's some considerations. As stated before, how many catheters are they receiving through their insurance? And is this causing the frequent UTI? Now, even if their insurance is only going to cover a certain amount, having some education in terms of how they could either maintain the catheters that they have to keep them clean, or even providing them with information on how to be able to purchase their own catheters, or organizations that will provide them with free catheter care. Same thing as I said before, insurance only reimburses for a wheelchair at least every 5 years. So you don't want to prescribe somebody a random piece of equipment emergently, since they'll likely be required to use it for 5 years. Someone comes into your clinic, they are really having a hard time walking. Don't just get them a wheelchair and then refer them to the wheelchair clinic. Refer them to the wheelchair clinic, hold off on getting them in the wheelchair, because we just don't want to interfere in their ability to have functional equipment going forward. Okay. Transportation, I mentioned transportation before. How is our patient with a wheelchair making it to their appointment? Are they using Access-a-Ride? Are they using an ambulette? Are they using an accessible taxi? Are they using public transportation? So just having that knowledge, if you work on 102nd Street, you know that it's very hard to get up 102nd Street to drop somebody off an appointment. So maybe if you know that somebody's coming via an Access-a-Ride or an accessible taxi, to have that conversation in advance of maybe arrive a little bit early, because you know that you're going to have a hard time getting up the street. Access. Access consists of a lot of areas in the healthcare experience for our patients once they enter the campus. There's the entrance to the building, there's the waiting room, there's the restroom, there's treatment rooms, there's the cafe. So here's some of the things that my patients have said to me. So one thing that bothers me about when I go in to see a doctor, spacing, the waiting rooms. There's never really enough designated space for someone like me in a wheelchair. It's often like playing Tetris in some form. Same applies to the treatment rooms. Sometimes you get into a room and they have to move everything in the room just for you to face them. So here are some considerations. Consider spacing in waiting rooms to ensure there are designated locations for persons in wheelchairs to sit. We have varying types of seats out there. We have wider seats, we have higher seats, but there's not often enough spacing between these seats for someone with a wheelchair to be able to comfortably be sitting in the waiting room. And even if we plan in advance to have that seating, sometimes people move chairs around. And so just having some knowledge as to what's going on in the waiting room so that the person with the wheelchair has a place to sit. If you're seeing somebody in a wheelchair, have the room configured prior to calling them back. I always make sure that when I bring somebody back into my room, and my room is the wheelchair clinic, that we actually have things moved aside if somebody's coming in their wheelchair, if they're going to be sitting in a chair. So we think in advance prior to bringing them back, just so that when they come in, they can comfortably come in and sit down and our session can begin, as opposed to having them come in a sort of chaotic environment where we're trying to figure out how to get them into the room and how to make it work for them. By doing that, it automatically allows them to come into an experience where they're already thinking, we haven't planned for them. We don't really know how to interact with them. We don't really know how to treat them. Support services. Who is the caretaker? Is their family present? Who assists with a bowel or bladder routine? Who helps them attend appointments? What happens when no one's there? Are they in bed? Are they in a wheelchair? This is very important information to have, because somebody with a permanent disability has all of these issues going on in terms of having to manage their self-care routine, potentially their bowel bladder routine. They have multiple medical appointments, whether it's somebody with a transplant on dialysis, they have impairments with their skin integrity. There are multiple appointments that they have to attend, and oftentimes having somebody help them get there to help them process the information is really important. What happens if nobody's home? Are they in bed? Are they stuck in the wheelchair all day long? So even if somebody has home attendant services or they live with somebody, that doesn't mean that there's always somebody there to help them. Oftentimes I've had patients sleep in their chairs, which isn't really, well, if it's a chair that allows you to change your position, it can support them. It's not necessarily the most healthy environment to be sleeping in. Insurance requirements. Now, this one I could talk about for days, and I'm not get on a soapbox and tout my documentation concerns and issues. But having some basic knowledge of what the insurance requirements are is important if you're providing care to somebody with a disability. Having knowledge of specific documentation for specific items for reimbursement. And if you don't have that knowledge, communicate with team members to learn. For example, if you have somebody who has needs for a mobility device and you don't understand all the documentation and you're not really sure what to do, ask us, reach out to me, shoot me an email. Say I have somebody who needs a chair and I don't really know what paperwork to fill out. When asked to complete documents in a specific fashion, just do so. Reimbursement requires specific language and will deny it if there's any deviation. And while we think that some of the language is a bit excessive, it is what it is. And so when we reach out to physicians to fill out specific paperwork or to use specific language, it's because that's what the insurance is requiring it. And so that doesn't just go in terms of mobility devices, but with some catheters and hospital beds, you need the same level of language. And so if you're not really sure of the language, just ask. So any questions of what I've talked about before? Okay, so I'm going to talk a little bit about, let's see, 11. Okay. I'm going to just go in conclusion in terms of what we found and what we know in research, that there are specific themes that come up for people with disabilities regarding their healthcare experiences. One is transportation, so being able to get to appointments. That's a very important one. How am I going to get to my doctor's appointment? I have an appointment tomorrow at 5. How am I going to get there? My accessoride requires that I plan 3 days in advance. So giving somebody an appointment to come in tomorrow isn't feasible. So thinking about transportation, finances and insurance support. We've talked about insurance and documentation and family supports. Feelings of being diminished and deflated. That's a really common theme among the population of people with disabilities. It's very common for someone with a disability to say that they feel like they're being diminished by the hospital care or by the staff that's working with them. And so having that understanding of what is their specific need along the lines of their disability, their secondary diagnoses, their social supports, their emotional support can change this feeling of being diminished and kind of drop it down to one of the lower end issues that come up among this population. Feeling forced to advocate for themselves. And the feeling forced to advocate for oneself really comes from the feeling diminished and deflated, and that nobody's listening to me and nobody is hearing what I have to say, and I have to scream to be heard. Inadequate information being provided regarding intervention. I being given the wrong medication for specific diagnoses. Being given the wrong information because I have a disability and I don't have the hand function to be able to use a specific intervention. And so having some knowledge about what are the symptoms of a specific disability can really go a long way. Access and environmental limitations. Again, I mentioned that before. Just, rearranging the room can go a long way to making somebody feel like they matter. Bringing them in and just starting the conversation and saying, hey, come on in, so let's talk, and I reviewed your chart. And that sort of can just start a session off really well. This is being too short. Now, that's one that I know that we can't really manage a lot because of just the fact that we have such a large population. But, if you provide all the information and you listen to what somebody has to say, even a short visit isn't going to feel like a short visit because they're going to feel like they're heard. And then lastly, feeling invisible or viewed as incompetent. And the worst thing that we could possibly do to any patient that comes to our door is making them feel incompetent or feeling invisible. This is their life. This is what they're living on the day to day. And who are we to tell them that, this part of what they're asking us isn't important. So it's really important to make them feel like they're heard and they're not invisible. Okay. So we can and should do better. This sort of a level of engagement, going from pity to sympathy to empathy to compassion, is really where we should be headed. We should be acknowledging that somebody is going through some level of suffering. We should let them know that we're aware that they're experiencing something, either a health crisis or an emotional crisis, or they feel like they're invisible, not acknowledged, and help to be present with them and be compassionate and show some semblance of empathy during our session. Some of the keywords and thoughts that came out of the mouth of a patient of mine with disability were empathy, patience, safety, creating an environment where everyone feels safe and comfortable, and to speak to them using language they understand. And so that's really, these are really very, very simple asks from the disability population for us to actually, acknowledge that they're in a difficult situation and show respect for that we should be patient. If they come in and they've had a really rough morning, just let them talk. If there's something going on, be patient and listen to what they have to say, to make sure that they feel safe and comfortable. So bringing them into a room that's been set up for them in advance, making sure that they feel safe and that they feel like they're in a comfortable environment. And then using language that the person with a disability understands. It seems, again, like a no-brainer, but clearly if these are keywords coming from patients who are in our Mount Sinai network, then it's clearly something that various patients are experiencing. So I just want to thank you. Does anybody have any questions? And if you do, just throw them into the chat box. And if not, then you can always feel free to reach out to me. Again, like I said before, you can always come and see me in my clinic. I am on the second floor in the CAM building in 17 East 102nd Street. you just shoot me an email. It's jenny.lieberman@mountsinai.org, and we can set that up. Okay. All right, everybody. Thank you so much for your time today.
Thank you, Jenny. Everyone, if you can, I just wanted to thank Jenny for joining us, but I do have some questions for you, Jenny, for myself. We'll just give the participants a chance to come up with some of the questions or comments and put them in the Q&A function. So first of all, thank you for sharing your email with us. We appreciate that. And if somebody, I'm not sure what the makeup of the participants are, if they're clinical or non-clinical, but if somebody wanted to, if they feel there's a need for a Hoyer lift or a wheelchair scale in their practice or their office, how would one go about requesting it, or who should they reach out to do that?
So that often is specific to the practice in terms of the funding component. But we can always, I've had multiple departments reach out to me for recommendations for different types of scales, and we've provided them with varying manufacturers and locations where they can be purchased from. And that would be based on need for the individual department.
Okay, great. And how, I mean, the information you presented today was really, really interesting, and I think very valuable. How can providers and other clinical staff that do work with this patient population get this information? We're offering it this month, through ODI Awareness Month. Do you share this this content in grand rounds or journal clubs, or how else could people access this information?
Well, I know that this is recorded, so they can always get that. I try to do pretty regular in-services or meetings with various departments just to provide them some education. As I said early on, I'm a huge advocate for my patients. It's one of the reasons why I continue to come in on a day-to-day basis, because I feel like advocating for our patient population is really one of the most important roles that we can have as healthcare providers, especially for the population of people with disabilities, because I'd say 90% of the people who come through my door don't know how to speak for themselves in terms of what their needs are in the healthcare setting. And so I do regular in-services, but I'm always willing to, if somebody is in the department and they want to have an in-service provided to their department, again, just shoot me an email. Okay.
And so these in-services, would it be very similar to what we just heard today, or do you customize it to?
I can absolutely customize it to the specific department, and I have. If it's some, I've done ones to palliative care. I've done them to IMA, and so they tend to be more specific to the departments as are requested. So, I've done anything from talking about the population disabilities to talking about the insurance components and the equipment, and so yeah.
Yeah. Can you talk a little bit, I know your specialty is you're in the wheelchair clinic with wheelchairs. Is there any key takeaways you want anybody on the call to know when it comes to, assessing wheelchairs or making that requisition for a wheelchair?
Sure. Yeah. So know we're here, know that we exist. And so that can really, you can always, I have lots of physicians that call me and email me to even see if a referral is an appropriate referral given insurance needs. Every day I get phone calls from doctors and emails from doctors, either through Epic or through Outlook, with a specific patient who has specific needs, and do I think it's somebody who we could get equipment for. But just, kind of knowing, I guess, take a step back and think, would you want to sit in what that person is sitting in, for 12 hours? Would you want your parents to sit in what that person is sitting in for 12 hours? And if you don't, then you should be making sure that they're being seen for something that's more customized.
Okay. Great. I don't see any questions in the Q&A. I do want, my last question refers to patients specifically. Some of the quotes you shared were I think very, some of them were concerning, in terms of how isolated or how excluded they feel. I don't know if they were all Sinai patients or what, but do you work with patient experience at all to communicate what you hear so that we can enhance the patient experience for these patients in general?
Probably not as much as I should. But I think that it's something that would be, I've had these conversations with individuals before. As I said, 2 of my best friends are wheelchair users. But I think when I was preparing to do this presentation, I like you said, I was kind of taken aback that I had some of these statements that were said about, our own healthcare environment, our own institution. And so I do think that it's something that needs to be kind of taken to the next level, next step. Again, if it's the patients that keep our doors open, and if we can't provide them with a place where they feel safe and comfortable, then what are we doing?
Yeah, exactly. All right, I'm gonna see if the participants have any questions or comments for Jenny today. It's been a quiet group. Okay, well, on that note, Jenny, thank you so much for joining us.
Sure. And again, if anybody has any questions after the fact, don't hesitate to shoot me an email.
Yes, and thank you so much for raising disability awareness for Disability Awareness Month with Office for Diversity and Inclusion. And we do have 2 more speakers this week. And, we welcome you to attend those, and please check out your weekly broadcast emails with the registration links if you haven't already registered. Okay, so the recordings will be ready in a few days, and I will share it with everybody who registered.
Thank you so much, Mary.
Thank you. Take care, everybody. Bye-bye.
Bye, guys.